Thank you for viewing our broadcast on Vermont Health Connect Employer Decisions. I'm Joe Bergeron with the Association of Vermont Credit Unions, and we're broadcasting today from Colchester's Vermont office. There are only 98 calendar days left before employers of 50 or fewer in Vermont must have their existing or new employee health insurance on the Green Mountain State's new health insurance exchange. So on the first of the year, all employers, including the Association of Vermont Credit Unions and all other small employers in Vermont, are going to have to be on the new Vermont Health Connect program. But there's a lot of things that need to happen between now and then, so we don't have until January 1st to make everything happen. For some companies, it will be major change, and for some it will be a fairly seamless process. Either way, there are a lot of issues to consider, and that's why we've asked Stephanie Pigeon of Affiliated Associates to join us here in the Association of Vermont Credit Unions office to help guide you and us through the discussion that we're going to have this afternoon on the whole Vermont Health Connect program, what your options are, what decisions you have to make, what actions you have to take between now and the first of the year, and review a timeline and hopefully answer some of your questions. Before we get started, I want to encourage you to ask questions and make comments using the chat feature on the right-hand side of the live stream player you're watching right now. Hover your mouse over the lower right of the video and you'll see icons to change the quality of the video and adjust the volume. In about a week or so after this broadcast, we'll archive an edited version of this event on our YouTube channel. Just search for Vermont Credit Unions, one word, no spaces, on YouTube for this and all of our other archived events. Our speaker today, Stephanie Pigeon, is from, as I already mentioned, Affiliated Associates. And that organization works as an independent broker and an employee benefits consultant to Vermont businesses. And they've spent, I would guess, many, if not most, of their waking hours in recent weeks and months learning about and keeping abreast of all of the many changes taking place in the Vermont health insurance landscape having to do with the exchange. And so now, to get us started on the path to working with Vermont's new health insurance world, let's turn things over to our presenter, Stephanie Pigeon.
Join us for the next hour to hour and a half. I'm going to start out in the first couple of slides of our presentation just making a quick comment about a few things from a national perspective and then from a state perspective, and then we'll go really into the details of what's coming up here in Vermont. The first thing is that from a national perspective, you probably are aware not every state in the nation is implementing an exchange. Some states have opted not to implement exchanges while others are kind of in a mixed category. I just share that with all of you because, interestingly enough, in one of my earlier sessions today with an employer, I was dealing with an employer that has employees in Maine, New Hampshire, Vermont, Tennessee, and Pennsylvania. So you can only imagine what that discussion was like because some of those states are not even implementing exchanges. And in states where there's not any state exchange going into existence, the federal exchange is supposed to come into play, but those are not necessarily up and running. So that particular individual or that business has a rather daunting task of determining how to handle that situation. The next item was really more or less just a recap for all of you before we go into the details. This is more of a timeline. You all are aware that we had the Green Mountain Care Board put together in 2011, and then the stages of stage 2 being 2014, what you have to comply with, and ultimately what the state of Vermont would like to do is they'd like to transition by 2017 a single payer concept where we'll all be in one plan, known as Green Mountain Care. One thing that's very unique to Vermont is that we are the only state in the nation that requires people go into the exchange and that there's not any outside choices. What I mean by that is if I'm an individual here in Vermont or a small business here in Vermont, I have to go to the state exchange. I cannot in the future go directly to Blue Cross or MVP to buy my insurance. So that's a bit different than any other state, and that's not necessarily how the federal act was set up, but that's what we're opting to do here in Vermont. So what I'd like to do is I'd like to spend a fair amount of time on who is and who is not impacted by this and touch on some really critical business decisions for all of you. I think the key one being, are you going to go to the exchange as a group or might you consider dismantling and having your employees go to the exchange individually? I also have had numerous questions about health savings accounts. Are they available? If so, what plans would we choose on the exchange, and how will that play out for 2014? And a few points of interest and so forth. So let's start out by talking about who is impacted and who is not impacted by the Vermont Health Connect. Catamount. Catamount is really important because you may very well have employees at your place of business that are currently on Catamount. They qualify for it. Starting January 1 of 2014, if anyone is earning an income greater than 133% of the federal poverty level and they're on Catamount, they will have to enroll in Vermont Health Connect. If they're on Catamount right now and they're below 133% of the federal poverty level, then they'll actually stay on Catamount and they'll be reevaluated during the course of next year, at which time they may very well qualify for Medicaid, or they'll have to go into the exchange at that point. You may also know folks that are on VHAP, and for folks that are on VHAP, they'll have to enroll in the exchange as well. And the reason so many of you are here is because many of you are small groups, less than 50 full-time equivalent employees, and a full-time equivalent is someone working 30 hours a week or more. And you have to go into the exchange on January 1 of 2014. I also have folks out there that are not covered by Medicare necessarily. They might just be direct with MVP or Blue Cross today. And those folks, if they're under the age of 65, will have to go into the exchange on January 1 or during their renewal time next year. I've gotten lots of questions from retired military members who have TRICARE. Will we have to do anything? Or my folks who have Medicare supplements. Or folks that are turning 65 who are asking me, will I have to go into the exchange? And the answer is no. They can certainly stay on their TRICARE plans. You can stay on your large group plans if you're with a large group employer or your spouse is and you're covered by such. So you won't have to make any changes. Or if you're on Dr. Dinosaur, and by the way, we have many employees whose children lots of times will qualify for Dr. Dinosaur. Those children will be able to remain on Dr. Dinosaur next year because Dr. Dinosaur is considered a Medicaid program. So I hope that poses some clarity as to who and who is not impacted next year. The timeline. Timeline is crucial. Right now, I think, is your planning time, really in September through mid-October, where you want to determine how are we going to handle this. Are we going to go as a group, or are we going to dismantle and have our employees go individually? A few key dates on this timeline. December 15th is definitely one of them, but I'm actually going to ask you to make note and jot down November 30th if you're taking any notes, because if you're going to go to the exchange as a group, which I think many of you will, you're going to want to make sure that you elect and set yourself up as a group plan in the exchange, and be sure that you have your employees choose their plans, as well as supply a premium check to the state of Vermont by November 30th. If you do that by November 30th, that means that your billing will be accurate for January 1. Everyone will receive their cards, at least I'm being promised, that's my caveat, that everyone will receive their cards by January 1. So the suggested time frame for that for businesses or organizations is November 30th. The other drop-dead date, if you will, is December 15th. Have your premium in by December 15th to at least guarantee that people receive cards. So those are some really important times. You all noticed that I commented that you'll pay your premiums to the state of Vermont. You will no longer pay your premiums to Blue Cross or MVP directly. The state of Vermont will take the premiums that you submit and then will distribute them accordingly to the carriers. So some of the key benefit decisions that you really have to think about are, do I enter this exchange as a business, or do I encourage my employees to go as individuals? And I think for many of you, your health insurance has been a core benefit. And that's probably the first question I would ask of many of you if I were consulting with you one-on-one. The second really key thing is, at what percentage levels have you been assisting your employees? Have you been assisting them at 70% or even 95% of the premium dollars? If you have, then you're more likely to go to the exchange as a group and continue with some level of assisting that's equivalent to what you're doing today. Will your employees pay more if you sent them by themselves? Very possible. We'll get into some of the subsidy calculations a little further down. And what happens in the future, if you go as a business, you'll still continue to deduct your premiums like you do today. So your premiums are still tax deductible if you go as a business, and the premium contributions that your employees are putting in will also be pre-tax. So again, I repeat, if you do that as a group, you still get the same tax benefits that you do today for both your employees and for yourselves as an organization. The other item at the bottom of the left-hand side is commenting on tax credits. Tax credits are available to employers today. There's several criteria that you have to meet. One is you have to be a group of less than 25 employees. Your average wages have to be $50,000 or less. And you have to be paying at least 50% of your employee premiums. If you're doing all of those, then I'd suggest you ask your tax preparer if there's any opportunity for a tax credit, which today is 35% of the premium dollars you're spending, and next year will be 50% of the premium dollars you're spending. Very few people qualify. I'm not a tax advisor. I suggest you bring that to your tax preparer and ask if there's any opportunity for such. So you'll all notice those are kind of the bullet points that I've brought up on the screen with regards to going as a group. The only way in which people can qualify for subsidies, and I use only cautiously because I'll explain a few other ways which people can access subsidies, is if you do not offer a group plan and your employees go individually to the exchange. So there is no group offering at all, they can go individually. The other way in which they might access subsidies is if you do not fund your premiums at a high enough level on the group chassis. In other words, if you only maybe offer them a group plan and provide 10 or 20% of the premium assistance, because then you're ultimately making your plan unaffordable. If anyone has to spend more than 9.5% of their gross income, then technically the plan is unaffordable, and therefore they may qualify for subsidies. So keep those things in mind. That's where it's really difficult as employers, because you're not always clear as to what the tax filing status is. You know exactly what your individual employees are making, but you have no real idea what their household income might honestly be. And because we're rolling into 2014, the individual mandate takes effect, which means that folks either have to buy insurance and pay a premium, or they're going to have to pay a penalty. One of the things I commented on early on when I first brought up my list of concerns, or the things we talk about, are the consumer-driven options, which are really your health savings accounts and your health reimbursement accounts. Health savings accounts will still be available on the exchange next year. There are 3 plans that are HSA qualified. And I've put on the screen what the contribution levels are this year and what they'll go to next year for everyone. Health reimbursement accounts are promises from you as the employer to your employees to access dollars to help them offset their deductibles or their copays. Health reimbursement accounts will still be available next year, but only if you provide a group plan, unless they're a standalone dental or vision only. So you can still promise your employees dollars through a reimbursement account, but only if you take your group to the exchange in a group format. So let's continue down the vein or the thought process of entering as a business. I think the key thing to begin with is you really want to focus on a defined contribution now. And defined contribution is nothing more than setting a flat dollar amount. It's real important that if you go to the exchange as a group, that you not continue to do it in the same format you might be doing it today. You may very well be offering to cover 90% of your employees' premiums at a percentage level. And by the way, the national average is 70%. And when I look at the employee groups that I work with, or employer groups that I work with, when I've done an analysis of the hundreds of groups we work with, it really does balance out to about 70% of the employee's cost. I have some groups that spend 95% on just their employee only, and then many other groups that might provide 50% for all tiers. So it does balance out at that. The one main reason that you cannot go to the exchange and say, I will cover 70% of your premium is because, you'd be creating a discriminatory situation. If somebody in the plan chooses a platinum, you're going to pay a higher level if you opt to go to the exchange and tell everyone you'll pay 70% of their premiums, because someone may choose platinum and someone else may choose bronze. So it's crucial, if you're going to go to the exchange, that you choose or convert what you're doing today to a flat dollar amount, and maybe you make it $400 a month or $300, whatever the magic number is. The next piece is that you may certainly contribute different amounts, whether they're single, two-person, or family. And you'll notice even in your exchange review that you'll see there's a 4-tier structure: single, two-person, employee plus children, which is a little less than the current family status, and then the family plan pricing. You are allowed to say, we will offer $250 as a flat dollar amount to the single, $350 for two-person, and maybe $450 for family. That's acceptable. You may do so. The one thing I caution you all, and I put this up here, it says employers may fund premium by class. You may fund differently from part-time to full-time, but I caution all of you, I currently have a question with the state of Vermont and the folks that are putting this all together. I have told them that from a discriminatory standpoint, I really encourage most of my employer groups not to break this down by class. So in other words, don't fund your management team differently than the rest of the employees, because once the ruling is finalized from a federal level, I don't think that's going to be an option. So I caution you, but I put that up there because in our training from Vermont Health Connect, that was mentioned as an option, and I'm cautious of it. There are only 2 ways in which you can actually access the exchange as a business. First is you could choose to offer to allow all your employees to pick from just one carrier. So you could say you may enter the exchange and pick any of the plans you want on Blue Cross, or any of the plans you want on MVP, or you have access to everything on the exchange and you can choose any of the plans between MVP and Blue Cross. Now, someone asked me in a session this morning, why might I choose? Why wouldn't I just leave the entire option up to my employee base? Well, remember the person I described when I first was commenting about the exchanges, and I have somebody that's got employees in Tennessee and Maine and Vermont and New Hampshire? My first thought is we need to make sure we're cautious and that all those employees have a proper network to handle that. So in that situation, we are going to make sure that those employees only have access to Blue Cross, because that's going to offer a national network. So that's an example of a situation where I might steer that group to choose one carrier and then let the employees pick from within the carrier choices. So that's very, very important. The last couple of things I have on this particular slide are really about we need to let Vermont know you're going to access the exchange. There's one application for you as businesses. And then finally, there'll be an aggregated bill. The bill will come from the state of Vermont and not from the carrier. Why? Because you may have, again, 2 people that choose an MVP plan if you open it up, and 1 person that chooses a Blue Cross Platinum and 1 that chooses a Blue Cross Bronze. They'll aggregate that all onto one bill and send that along to you. And a question that's come up from so many of you has been, okay, so if we go as a group, we'll then figure that out and do the difference of whatever we're promising, can that come out of payroll on a pre-tax basis to offset what they're doing? And the answer is yes. It'd function just like today, except you'd receive an aggregated bill instead of a bill that's just Blue Cross or just MVP. Number 6 is the compliance notice. I know many of you have received comments that you need to get your letter of intent out to both your full-time and your part-time employees by October 1. That letter of intent does not mean that you have to know whether you're going to the exchange as a group or as an individual, or encouraging them, pardon me, to go as individuals. That letter of intent merely means the exchange is here, it's coming, and we're making you aware of it. So I encourage you to use, we sent out samples from the Department of Labor. The 3-page form is the one you'd want to use. Use the first 2 pages. The 3rd page is elective. You don't necessarily have to give that one out. So keep your life simple and go with the first 2 pages. All right, I'm going to dig into the plans, understanding some of the key features. Sometimes this is a little easier when I have folks in the room, because I have them pull out the black and white sheet that's been posted to Vermont Health Connect, which takes all the plans and consolidates them into one page between MVP and Blue Cross. And it looks sort of something like this for those of you that are sitting out there. It's this kind of sheet. You've probably all seen it. I think what's most important, if you have one of those in front of you where you are, you may want to use that and follow along. But let's start out with network options. As I said before, Blue Cross Blue Shield is going to be an EPO, which stands for Exclusive Provider Organization. What that really means to you is that you have access to Blue Cross Blue Shield's network on a national level. So you can go to a Blue Cross Blue Shield provider in Ohio. As long as you go to a Blue Cross Blue Shield provider, you have coverage. If you go to a specialist that is not a Blue Cross Blue Shield provider, you will have no coverage. With the exception, like any plan, just like today, if you're traveling and you have an emergency situation, you're treated as in-network, whether you have an HMO or an EPO or any kind of plan, because you have an emergency situation. So that's going to be treated as in-network. MVP today, if you purchased MVP, you probably have an EPO, which means you have a dual network. You have MVP and you have Cigna. But MVP has opted to bring their HMO network to the exchange, which means you have access to MVP's network of doctors here at a regional level, which includes Fletcher Allen and Dartmouth, areas in New York, Vermont, and New Hampshire. If, however, you need to see a specialist in Boston, you'll have to get prior approval to make sure that you can do so. You may not get approval. So those are my concerns with regards to the networks, but that's how they're structured on the exchange next year. You will also see on that sheet, as you're doing comparatives, you'll see standard versus non-standard plans. The standard plans are the plans that were really set up and approved by Vermont, and they have to mimic one another. Blue Cross Blue Shield and MVP do not differentiate at all in their standard plans. So the first four that you'll see, of platinum over to bronze, all match in copay and they all match in deductibles. And then if you look over to your right, if you're on that particular slide, you'll see the non-standard plans, which allowed MVP and Blue Cross to differentiate. So Blue Cross's plans may have very different deductibles than MVP's plans do. Important acronyms for you to be aware of. If you see high deductible health plan, so HDHP, which is high deductible health plan, or CDHP, consumer driven health plan, any of those acronyms mean that that's an HSA qualified plan. There are three plans on the exchange that are HSA qualified. The standard, silver and bronze, simply state above it, high deductible health plan, and you'll see that. Then you'll see one bronze plan that's the non-standard Blue Cross. That is also a high deductible health plan and allows you to put HSA dollars aside with it. The stacked and the shared, embedded and aggregate, those are terms that I think are really important for you to understand. And this now refers to when you have two people or more on a plan. So we're really talking about two-person and family situations. So many of you today, you may very well have a situation where you have two individual deductibles, up to two in a family. So that would be a stacked deductible. So for example, if I take the Platinum Blue Cross Blue Shield plan, which is a $150 deductible, and I go in for knee surgery on January 5th of next year, and I'm a two-person plan, I will only have to pay a $150 deductible because it's a stacked deductible. Two separate deductibles in a family. If, however, you look on your options for the exchange and you see that the high deductible health plan choices, those are all shared family deductibles, meaning that I would have to meet my full family deductible before any portion is picked up. So one example I know of is if I go in for knee surgery and I'm on the silver high deductible health plan, which is $1,550 individual deductible, it's $3,100 for two-person or family. I would have to pay $3,100 in my deductible because it's shared, meaning all of us have to meet that one deductible before the carrier spends anything. Aggregate and shared are exactly the same terms. So if any of you are looking at the Blue Cross Blue Shield cheat sheet, you'll see the term aggregate. That means shared. That's really important. The other piece is coinsurance. So many of you may be on plans today where after you've met your deductible, your coverage is 100%. It's been very easy to explain to the employees. Going into next year, every single plan on the exchange actually has coinsurance, meaning after you meet the deductible, there's some level of share. That share may very well be 20% or 50%, depends on the plan. And then you hit a maximum out-of-pocket. And you'll see on many of the sheets the medical maximum out-of-pocket. The federal cap, for all of you to be aware, is $6,350 for a single and $12,700 for a family. So those are the federal maximum out-of-pockets. In today's world, copays do not help meet the federal out-of-pocket maximums, or there's not any federal, pardon me, but they don't help meet the out-of-pocket maximums. In tomorrow's world, everything will go and help meet the out-of-pocket maximums of $6,350 and $12,700 for family. The next item is really moving into the integrated RX and the mandated protection on prescription that came into effect last year. If you were not aware, your plans last year have a cap or a protection for prescription purposes, which for an individual is $1,250, and for a family of 2 or more is $2,500. If anyone were to hit those levels in their prescription costs, whether it be through copay or through an HSA style plan, and you have to pay out all your prescription costs potentially, if you hit those levels, your prescriptions are then covered 100% by the carrier. That will continue and flow through onto the exchange plans. What's real important is the integrated RX and non-integrated RX. If anybody has the black and white sheet I showed you, if you're looking at a Blue Cross sheet, I'm not sure which one's the best, but I think what's most important for you to understand is that if you're looking at the black and white sheet on Vermont Health Connect, which shows all the plans, if you look all the way over to the right-hand side, you'll see an MVP Bronze plan that says no, it's not integrated, but the max out-of-pocket is $6,350. If you move one column over, it'll say yes, it'll say yes on the first one, it'll say no, it's not integrated on the second one over, because what happens is the max out-of-pocket medical is, I believe, $5,100, and then you need to add in the $1,250 exposure. So in some plans it's integrated, and in some plans the prescription is not integrated into the out-of-pocket medical. All right. Pediatric dental. Pediatric dental, I've been learning more and more about that right up to 2 days ago. One of the essential health benefits of the Affordable Care Act is to make sure that pediatric dental is available to everyone in the exchange plans. And that is coverage to age 21. Someone would be on the plan, of course. If they turned 22 in that year, they'd stay on to the end of the year, and then they would renew and no longer have the pediatric dental portion. I have a slide further down that talks more about the pediatric dental, but I want everyone to be clear that pediatric dental includes a checkup 2 times a year, covered at 100%, and then if you have anything that falls into the basic categories, it would be 30% paid by you for the pediatric situation, and then it would be 50% for something that's major. I caution all of you right now in that pediatric dental in many cases is after the deductible. So since it's after the medical deductible, it may not be an enormous value to many of your employees. And I would really encourage you, if you offer dental plans right now, standalone dental plans, please keep them available. Because those standalone dental plans will cover your adults as well as your children, and they're guaranteed to have those preventative measures and so forth immediate. Now, for those of you that are looking closely at Blue Cross Blue Shield, I can tell you that the pediatric dental is before the deductible on the Platinum, Gold, and Silver standard plans. So there would be immediate coverage for pediatric dental on the Platinum, Gold, and Silver standard plans. Why? Because Blue Cross is telling me the best way to determine this is that if the specialist office visit copay is before the deductible, then so will pediatric dental be. Okay? The other thing is pediatric vision exams. The copays vary depending upon the plan. Some are $20 for an eye exam and some are as high as $80 for an eye exam. And not every plan covers the pediatric vision before the deductible either. So that's a case-by-case situation to determine which plan does so. And lastly, the non-standard plans versus the standard plans. The non-standard plans do have some health rewards, monetary health rewards. For example, if you go for an annual exam, Blue Cross might reimburse you $100 or cut you a check at $100 equivalent. The cap on those rewards is $300. I'm concerned because I think some of the standard plans might be more fitting to most of my clientele, because truthfully, you'll notice on the standard plans, anyone that's used to having a copay for their office visits up front, they'd be happier on a platinum, gold, or silver plan that's a standard plan. If you look at the non-standard plans, or what they might be calling their blue reward plans, look really closely at things such as the emergency room visit, the specialist visits. Anytime you see an asterisk next to an office, what looks like an office visit copay, I caution you, it's insurance. You always want to be cautious of asterisks. So I caution you because that means that you have to meet your deductible before those copays go into effect. So I repeat, I think I'm a little bit more comfortable in most situations encouraging you to look at your standard plans due to the copay structure. I can't get my thing to go down. Can you move? Mm-mm. No. Hold on, everyone. I promise I didn't touch anything.
Well, we're broadcasting the correct page, so you can just keep going.
Okay. Excellent. I'm going to find my spot. All right, I think everyone else is looking at the correct page, so I'm going to continue along. So I've really touched on quite heavily the group aspect, and now I'd like to take a moment and go into the pay the premium or pay the penalty piece that you're all seeing. If you're someone who does not take insurance next year, whether it's through your group, whether it's through your group or individually, then you'll have to pay a penalty to the government. So this again is for individual purposes. So if you're someone who does not take insurance, it's going to be a penalty. This penalty is due annually. So it's the greater of two. If you're an individual, you'd have to pay $95 or 1% of your income. And that's what you'd pay on an annual basis. Right about this time is when I have employers asking me, do we have to pay any penalties if we don't offer insurance? Well, my response to all of you is that no, you don't have any federal penalties to worry about right now, nor do you if you're under a group of 50. However, you do have to be concerned about the Vermont Catamount assessment tax. Even though Catamount is rolling into the exchange, you still would be liable to have to pay a $497 annual fee for anyone who is not insured in your group. Many of you file that quarterly, and many times you probably just put 0 on the paperwork because you don't have that situation in your groups. But that might be an example of an employer that decides that they're no longer going to offer coverage and folks might go without. They may very well have to pay the Catamount assessment tax. Now I'm going to move into the subsidy piece. So all of you are looking at a screenshot which shows the subsidies, the incomes on the left-hand side. And what I did is I demonstrate this from the federal poverty level and percentages to actual dollar amounts from an income standpoint. So if you're looking at 138% of federal poverty level, you'll see that that's equivalent to $15,866 of a single income earner. The other item you'll notice at the top of that column is I've put here household income. I want all of you to understand that this term is being really used rather loosely. It's tax filing status, not household income. Today, folks that qualify for Catamount, it's based on household income. So you may have several people earning an income that's declared for that household, and that's how Catamount's determined whether or not they receive Catamount. Next year, for exchange purposes, it's based on your filing, your tax filing status. So you could have 3 people living in a household, but you may very well have 3 people filing separately or as singles. This also brings about another really interesting thing, which is so many of you may have your 25-year-old child on your health plan. And I just had this situation happen with one of my clients the other day. They have a son. It makes them a 3-person plan, so it puts them in the family premium category. And the discussion was this: well, my son is working, but he earns very little. He's 24 years old. Why would I keep him on my plan? There's no reason to keep the son on the plan because he's going to receive such significant subsidies that it makes sense to have him go into the exchange as himself and keep the two of them together as a couple. So we may see a lot of people doing an analysis of that as well. Now on the right-hand side of the screen, you'll see percentages. And those percentages depict the maximum you're going to have to spend of your income. So if you're someone who is earning $28,725, you're at 250% of the federal poverty level, you're a single filer, the most you would have to spend is 8.05% of your income, and the difference is picked up by the federal government. You'll notice I have a little bubble over to the right-hand side that said Vermont is also going to reduce some of these. Vermont's subsidy is an additional 1.5%, up to 300% of the federal poverty level. So because I'm getting fuzzy on my math at this time of day, let's take a look at the 138% of federal poverty level. If you're earning $15,866 as an individual, the federal government says you will not have to spend more than 3% of your income. Now consider what Vermont's going to help you do, and it's only going to be 1.5 because you reduce 3% by 1.5 and you would not have to spend more than 1.5% of your income. You will not receive these subsidies directly to you. These subsidies will be paid to the state and then distributed to the carrier to cover the other portion of your premium. You will be billed solely for the portion that you owe. This is just a graph that depicts another way of how to look at that. It's really saying the same thing. It's just making it clear that you reduce with Vermont 1.5% less than what the federal government's going to subsidize you at. And then once you hit 3% of federal poverty level, it goes to 9.5. I'm backing up just for a moment because I think it's important for everyone to understand that if you're a family or even a single, if you're a single that's earning $47,000 a year, you fall off the subsidy cliff is what I call it, meaning there's no subsidy to you whatsoever. If you're a family filing and you make $96,000 a year, there's no subsidy to you whatsoever. So that's my subsidy cliff comment. And again, this is a repeat of that same graph. Here's something else you should all be aware of if you haven't already seen this on Vermont Health Connect. And this again continues with the individual going to the exchange and receiving subsidies. There's a cost share component on top of the fact you may get some assistance with regards to your premiums. So I'm really overwhelming you today. I'm throwing everything at you at once. This is really just showing you the federal poverty levels on the left-hand side, and then it converts it again to numbers of a single household or a family of 4 filing. And then it takes you across and shows that the deductible maximums, this is a way of capping folks' deductibles and their maximum out of pocket. So there's actually a bit of a reduction in their maximum out of pockets if they qualify for these items. Again, remember, this is if you do not take your employees to the exchange as a group, you let them go themselves, they may qualify for these subsidies. But so many of you are funding at high levels that I still think many of you might consider taking the groups to the exchange as a group. So let's just take a moment and look at an actual calculation of this. The federal government had to use a benchmark plan. They used the benchmark being the second lowest cost silver plan. And in this particular situation, I used the Blue Cross high deductible health plan, which is $412.83 a month for a single premium, and $1160.05 for the family premium. I then decided we'd look at someone who's earning $22,980 a year. This very well could be someone that might be working part-time too, that's on Catamount today. That person will not have to spend more than 6.3% from a federal subsidy level of their income. So they will receive $258.85 in assistance, which goes direct to Vermont, and they would pay the difference in the bill of $153.98, not taking into account the fact that Vermont will also assist them, so they may only spend about $100. Then I just did the same thing from a family perspective. That's all you're looking at. The next screenshot is something I see regularly. I see so many of my individual employees earning roughly $37,000. And then I see families who maybe have an income between someone earning $50,000 and somebody else earning $30,000 in the household. And so these folks would not get any additional assistance from the state. They would only get the federal subsidy assistance, and this is a real depiction of where they would land. Again, using the benchmark plan, the second lowest cost silver plan, this individual would receive $119.91 for subsidy, leaving them having to spend $292.92 a month. Now right there is a good pause point, because that is why one of my questions to all of you is, what are you doing as an organization? If you're paying 70% or more of your employees' premium right now, you're probably subsidizing them at a much higher level than what some of the federal government subsidies will end up being. And again, it's another depiction of the family scenario, which is $526 in subsidy, leaving them spending $633.33 a month for the family coverage. Okay? And understand that the subsidy that they're being given is based on that plan. If they want to buy a more comprehensive plan, they'll spend more, because that's the max of the subsidy they'll receive. Now that everyone's having fun, because I can see it on the faces in the room, I would like to move into some points of interest, just in a general sense. And the first thing is if everyone is enrolling into the exchange, which I believe most of you, although I don't know who exactly is listening, but I believe most of you have January 1 renewals. If you renew January 1, you'd roll into the exchange for January 1. However, I think it's important for you to know, if your renewal date is sometime mid-year, such as July or August or even in the fall, you do not have to move your group into the exchange until you renew. And I have a lot of employer groups that renew at various times through the course of the year. So in a sense, they're really postponing. They don't have to enter until they get a little further into the year. But as things all move into the exchange, the open enrollment time is always going to be January 1. Some of my employer groups have asked, might I take my employees as a group in year 1, but what if we decide it's better for us the following year to dismantle our group plan and go individually? The answer to that question is that you may certainly make an adjustment and change the following year. You just can't do it mid-year. Okay. The other thing is, I don't think many of you have a very lengthy waiting time when you hire someone new, but I do have a fair number of clients out there that have their employees wait 6 months sometimes before they allow them to come on to their health plan. The federal government has put a cap of 90 days on the wait time for your new hires to come on to the plan. I caution all of you that if you have a 90-day wait today, I would ask you to make it a 60-day wait, no greater than 60 days. The reason I caution you for that is because if you have a 90-day wait and you cannot get the person on to the first of the following month, you could end up finding yourself moving into a 100-day wait, and you're not meeting the compliant aspect. So make your wait time 60-day maximum. If I have anyone in here that has employees in other states, because maybe your organization is right on the border of Massachusetts, New York, or New Hampshire, then you can certainly set it up so that you can put everyone into the Vermont exchange. And if that's the case, I may encourage the Blue Cross one, like we discussed, because of network. However, you also could set it up so that you could assist them. They could do it through the group in New Hampshire. They could do it as a group of folks that are actually residents in New Hampshire, New Hampshire, New York, or Massachusetts. You could allow them to go into their own exchange. It gets a little complicated. I think it might be easier just to deal with one aggregated bill from Vermont and put them on the Blue Cross Choice platform. Individuals, that's just some information for you on that slide, letting you know when they'll be billed and so forth. The other thing is the subsidies and the income verification. You've probably seen the federal government is really in an uproar with regards to subsidies, and this might be one of the reasons why the House is proposing what they're proposing and why the Senate is back and forth and so on. And part of this is that when people enroll themselves, they have to enter their income. And in some situations, they may have to estimate their income. And there's no communication right now with the Federal Data Hub to cross-reference that. So what happens is you may very well enter your income to be $28,000, but when you get to the end of the year, you may have made $35,000. There'll be a true-up at the end of the year, and therefore you could ultimately owe the government back some subsidy money. The other component, the last bullet point on this slide, is the individuals and qualifying events, excuse me. If you have a group plan, qualifying events will still exist. If someone gets married or someone gets divorced or there's a child born or someone loses a job, that's a qualifying event, which leads me to COBRA. If you offer a group plan, you still need to offer COBRA when people leave. And they still have their 60-day window, so nothing is changing for them to elect COBRA continuation. What's really important, though, is let's assume that somebody leaves their place of employment. You offer them COBRA, and they have their 60-day window, and they don't elect anything. And they're now 90 days out, and they didn't pick up anything. What will happen is their penalty, that individual mandate that's got the 1% of income penalty, will start to calculate because they will not be able to just enter the exchange at their whim. Very different than today. One of the things that happens lots of times in my practice today is I will get a phone call from people who say, you know, I had things change, I couldn't afford COBRA. Could you please put us on an individual Blue Cross or an individual major medical plan with MVP? And today we can enroll you mid-year and do that. In the future we cannot do that. It's not available to you, which goes back to how Vermont is doing things very differently. In other states, any of the other states I mentioned earlier, if you called my office and asked for that, we would be able to assist you and we could get you coverage mid-year as an individual. So key point here, everyone will have to wait till January 1 if they miss their opportunities to take COBRA or that opportunity to be insured. I commented on the pediatric dental already and the pediatric vision. I think this is just a good visual for all of you to understand Class 1, no charge, simply means 2 annual checkups. And then the Class 2 type coverage might be something like a filling, and Class 3 might be something much more detailed. Okay? And the last bullet point I have on here is active care. That's actually an insurance product that our organization is using to help buffer some of the out-of-pocket exposures on these plans, whether you are in a copay plan or not. And it's unique because it encompasses a combination of a cancer policy, an accident policy, and a critical illness policy all into one format. And you'll hear more about that a little further down. So now let's talk about what strategies are available or what we might see coming into play a little bit more frequently or in more detail. And this slide is really focusing on cafeteria dollars. So many of our employers have really focused on just paying a large portion of premium, and that's been their primary benefit plan. I think what we're going to see is we're going to see more and more folks really looking into the cafeteria plan. And when you hear the word cafeteria plan, it's really a combination of many things. Right now, if your employees participate at any level, you're allowing them to take premiums out of their pay on a pre-tax basis. That's the premium-only portion of a cafeteria plan. So that's one piece of a cafeteria plan as it exists today. You also may offer flexible savings accounts. If you don't, you might actually consider those in the future because that might be a strategy, and we'll talk a little bit more about that as we move along. I just left earlier today a presentation with a group that is changing their benefits, and they're providing dollars in a cafeteria plan. They're providing a portion of it through FSAs. Another portion of it is just made available to their employees so that the employees can buy vision or dental if they want, or put those monies towards their dependent care costs. I think you'll see more of that coming along if you're not already doing that. One of the things I found a bit discouraging once all of the exchange plans were posted is that the out-of-pocket maximums are a bit high because so many of them are very close to the federal cap of $6,350 or $12,700. So from a creative standpoint, I thought it was important to offer to our clients or make you aware that plans, other plans such as the active care could be helpful to your employees. This is an example of a $10,000 lump sum type of plan, purposely chosen $10,000 would cover someone's out-of-pocket maximum and would pay upon diagnosis. So these are the types of things where if you have a cancer diagnosis, such as breast cancer, a $10,000 lump sum would be paid to you, and then you could do with it what you needed. So this is that program I was explaining to all of you. It's kind of wrapped up into one. And this gives an example. So it's one thought process. This gives an example of how it might work against one of the plans on the exchange. For example, the non-standard silver MVP HMO, just depicting your out-of-pocket maximum is $6,350. In this particular situation, let's say this person has a cancer diagnosis and it's a breast cancer situation. They'll receive $10,000 from that policy. They would also receive an additional $1,400 for chemotherapy, $2,800 for radiation, and another $900 for the hospital time that they spend. That equates to $15,100 made available to that person. And that would be enough to help offset the out-of-pocket maximum for them and leave them with some funds to help them in the short run if they're unable to work for a period of time. And to the right, I've given you a realistic, it's a live example of someone who's 45 and what the premium dollars would be. We're sharing this with our clients because it's very common. These types of coverages are common in England and Canada. We see a lot of them. Another example might be an accident type coverage, or the accident portion of the active care, how it would pay out if you had an auto accident. If you have an auto accident, you may very well have a broken leg, a dislocated shoulder, a variety of things that happen, and you might spend a little time in the hospital. What happens here is it's an accumulation of payouts that would be paid out to you from that policy, and you'd receive $2,980. Your actual out-of-pocket maximum from your plan is $5,750, but that would certainly help you meet half of it. So not in every case would you have enough to cover your full out-of-pocket maximum, but in some cases that may very well be helpful. And those plans are available to individuals as elective options, or they're available to businesses to consider as a whole. So that's just some creative ideas for all of you. And you're probably well aware of a lot of worksite offerings, but this product came to Vermont in March, and it's the only one that I'm aware of that encompasses all of those items in one. So I thought I might just share a couple of case studies with everyone. The first case study, and this is a live case, it's a small group of ours. And this small group has 2 singles and 2 families right now. And the company currently spends 50% of premium, whether you're single, 2-person family, it does not matter. They'll pick up 50% of your cost. If they consider going to the exchange, they realize, remember I said you need to pick a flat dollar amount. You have to define your contribution. You cannot do percentage. So we're considering $200 a month for singles and $500 for family. I put a little asterisk right there that says subsidy comment, which I want to share with all of you right now. If your organization supplies 100% of assistance for premiums for the employee only, you may want to continue to do something like that. Here's why. You could offer to pay assistance for your employee only, and if you do so, then the spouse and children could go to the exchange and receive subsidies. So you could specify that. That is why I wanted to make that comment right there. In this particular example, if this employer provides $200 to the single and $500 to family, they're assisting the family, so there is no opportunity for the dependents to receive any subsidies. And then when we calculated what our defined contribution is, that works out to $16,800 for the 4 people participating. And in this situation, unlike many of you, I believe you have very strong benefits. This employer group did not have any group life, and they didn't have any vision options for anyone. So we decided we would supply everybody with a small coverage for life insurance, and every one of the employees, the company picked up their vision plan. So our budget ended up being the same for a few additional benefits and still keeping them going to the exchange. And if the employees wanted to add their dependents to the vision, that's why it's listed below, if they wanted to add a child, they may do so. They could just do it through payroll. This same employer is struggling with the idea of not going to the exchange as a group. And one of the things we're thinking of doing is saying, okay, we will not go to the exchange as an employer, but we're concerned about our employees because we've always provided some level of benefit. The other key issue that's in this case study is that we have 1 or 2 highly compensated people, and the others qualify for subsidies, and we know this. So what's happening in this situation is we're looking at promising dollars through the cafeteria plan or through the flexible spending account. And instead of just covering the 4 people that need it on the plan, we're going to supply $1,500 to all of the 7 employees, projecting that they're going to spend 80% of the dollars, which means we'll spend $10,500. And then we're going to add in some other benefits because this employer has not had these. The employer is deciding that they'll buy the active care plan on everybody. They'll buy disability on everybody. And so many of you are doing it. So you might actually find yourselves if everyone in your groups qualified for subsidies, there may be a discussion with you about adding more dollars to your cafeteria plan just in general, and not necessarily premiums for insurance plans. So we ultimately land at the same budget standpoint for this group. We're right around the $18,925. We're spending the same money, and we implemented additional benefits for everybody. If we offer monies through the flexible spending account or through the cafeteria plan, the employees can still go to the exchange and receive subsidies. The organization can still deduct the dollars spent through the flexible savings account, and those dollars will help offset those high out-of-pocket exposures of deductibles and copays. So in some situations, you could bump up your FSA, the cap being $2,500, which you may or may not already know. Okay. The last slide is really about brokers and navigators. And if you're not already aware, all of the premiums that you're seeing on the exchange are not including any fees to the broker you may very well be working with right now. In the past, brokers have always been compensated in a commission structure, which is either a flat dollar amount paid to our brokerage firms or a percentage of premium paid to our brokerage firms. The state of Vermont has approved a $20 per employee or per individual per month fee that can be billed to you if you're utilizing a certified broker, and we have to be certified. There are 5 of us in our office that have completed our certification, with the exception of one last item this week we have to do. And there also was $2 million provided to the state of Vermont for the purpose of broker fees. That $2 million grant is being dispersed out to the tune of $7 against the $20 you might be spending for any of our services, and will be paid back to your organization on a quarterly basis until it runs out. Some of my clients understand how we're paid and were not aware of this. Other folks did know how this was working. So that's how a broker may very well be compensated in the future, or your broker may work with you with some sort of a servicing arrangement and determine a flat fee structure with you for education. Navigators are folks who are being trained to assist both employer groups and individuals. And you all are aware probably of the navigator organizations. Some of the chambers are involved with that. The grant money that's been made available for navigators is being distributed to those navigational organizations, and those folks are being paid in the form of salaries, really. They have about 3 days of education. I am a little bit concerned for some of them because they're trying to absorb an awful lot. Whereas if you're working with a broker, your broker may very well have been doing this for years. So I do caution. I've gotten some information from some of my clients that a navigator may have misunderstood something and told them something slightly inaccurate. So just be careful, please. Navigators do not have to be licensed. So that's another point. And Joe, I'm happy to answer any questions.
Thank you, Stephanie. We do have a couple questions, and from remote viewers. And the first one we've got goes back to when you were talking about penalties assessed to employers, and referencing $497 paid annually, and wondering if that's per employee or per employer.
Okay, so the question is with regards to the employer catamount assessment tax. That's the $497 annual fee. It's actually paid quarterly, so let me correct myself. You file it when you send in information to the state of Vermont on a quarterly basis. So many of you have had all of your employees covered, whether it's through a spouse or on your plan, that you've probably not had to pay anything, so you would just file a 0 on that. And I believe to finish answering the question, it is based on each employee that does not have coverage. The first 4 employees, you get a freebie, is probably the best way to say that. So you can have 4 people who are uninsured, but once you go above 4 people, you have to pay that assessment on each of the folks above the 4.
And a follow-up question, Stephanie, has to do with employee choice. If the employer offers a plan or a variety of plans, but the employee or one employee chooses not to participate, does the employer get penalized in any way for that employee that chooses not to participate?
The question is with regards to whether or not an employer will receive a penalty if you offer a group plan and yet the employee chooses not to go and purchase coverage. Because you are under 50 employees, we'll start there, even though it's been postponed, the federal penalty has been postponed. But if you're under 50 full-time equivalent employees, you do not have to worry about any federal penalty whatsoever. So the answer is no penalty there. Again, the only concern you have as an employer is if you now have more than 4 uninsured people in your group, you'd have to pay the catamount assessment tax. Was that clear?
Yeah.
Okay.
I just had a question in regard to taxation. I'm trying to understand this because I think there could be a number of different cases. Let's say an employer opts to no longer offer insurance, but decides it wants to make a contribution to its employees as a benefit so they can buy something from the exchange. How will that potentially impact the employee?
Mm-hmm.
They now used to have a non-taxable benefit. They now have cash coming in. How does that all work out in terms of taxation?
Okay, so the question is really with regards to taxation. If you opt not to take the employees as a group, but you'd like to give them monies to help them with their choices on the exchange.
That could be one example.
One
Or,
example.
You know,
Or how does it work even if you
or
go as a group?
the highest level of the plan was lower than what they were used to, so you want to try to give them a cash benefit to make up the difference. How's that going to work for the employee at the end of the day in terms of taxation, and will it impact them?
Okay, so I'm going to give you 2 examples, I think, with regards to that question, which is taxation impacts. If you, as an organization, take your employees to the exchange, if you take your employees to the exchange as a group, and you would like to assist them with additional dollars to help offset maybe some of the out-of-pocket maximums, then you would do that. My advice, what my agency would have you do, is we'd have you supply those through health reimbursement accounts. Not necessarily HSAs, that would be a discussion with you, but through a health reimbursement account. Why? Because you can now, because you offer a group plan and they're taking a plan, you can still have a health reimbursement account in 2014. You're not adding to their taxable income at all, so you're not harming them at all, but you're providing the funds they might need to offset their out-of-pocket maximums. That's a perfect way to do it as a group. Now I want to go to scenario number 2. If you do not decide to go as a group, and you say, I'm going to dismantle my plan, but I somehow would like to help people, how will that impact them? That's been the big issue. The big issue is that many of my employer groups started out by saying, well, I'm not going to do this anymore, and I'll just add money back into their pay. Well, that's not going to help anyone necessarily, because you're absolutely right. You'll pay more in taxes, and you could throw somebody over the subsidy cliff. You're going to reduce their subsidy levels by giving them money back in their pay. That's where, depending on whether or not you have the availability, if you're not offering a flexible savings account right now, and you'd like to dismantle and have everybody go to the exchange themselves, you could, as an employer, fund a flexible savings account up to $2,500 to help offset their exposure. And again, the good part about that is that that doesn't go into their taxable income. That's just a promise, but it's just using the IRS code of 125 instead of the HRA code. Have I totally confused you?
No, actually.
Or did I clarify?
Yeah, because
Okay.
that was exactly my fear was you're contributing to somebody, they then have to take out the taxable benefit, you know, so maybe for every $10 it nets to $7, but also it works against them because they're probably going to look at their gross income in terms of what their subsidies can
Right.
be. So.
So there is a way around it, but it's by funding it through the FSA. If you don't do a group plan, if you do a group plan, please consider HRAs. I want to tell you that 85% of our groups today offer a health reimbursement account or a combination of a health savings account and or a health reimbursement account. And people love it because they have dollars they can use against their maximums. Any other
Question, as far as full-time employees, we offer benefits if someone works 40 hours to be in the medical. So with the allotment of 30 hours designating a full-time employee, do we have to change our policy?
Mm-hmm.
So if you work 30 hours, you're considered full-time?
Full-time.
Okay.
The question was about full-time equivalent status and full-time employment. You are considered full-time at 30 plus hours. Are there any other questions?
Yes, we've got a follow-up question here. The employer offers insurance. All but 2 employees have coverage either through that employer or through another plan like Medicare or the spouse's place of employment. Will we be exempt from any kind of penalties?
Yes. So the question is with regards to a situation where you may only have 2 people on the plan, but everyone else in your group is currently covered by either Medicare, Medicare supplements, or their spouse's plan. Those folks are considered covered. So therefore, that does not impact you from the Catamount assessment tax. It's really folks who are not covered at all that start to calculate towards the Catamount assessment tax. And again, there's no federal penalty with groups under 50. I hope that answered that question.
Any other questions here? Okay, well, Stephanie, if I can ask you a favor, unless there's other points you wanted to cover,
Mm-hmm.
Do you mind highlighting for us one more time the drop-dead dates that are coming up, and then also extending into the future too, because I know the number of the size of employer that's covered
Mm-hmm.
changes down the road as we approach the single-payer plan.
That's right.
A few years down the road.
Yeah, so a few drop-dead dates. I'd like to comment again that November 30th is one that really sticks in my mind from my last Medicaid and Exchange meeting. Even though my timeline says December 15th, I really encourage you all to have your group enrolled and your payment to the state by November 30 if you can do so, because we're being promised you'll receive cards in time and your billing will be accurate. I do have to then also comment that you may have seen some recent articles that show that October is kind of a viewing time because the state is not prepared to receive your payments in October even. So I wouldn't be panicked thinking that you have to get everything done in October, but I would encourage you to really focus in and make sure everything's complete in November. The other item, Joe, was with regards to in the next couple of years, what's happening. Remember, everyone has to go into the exchange if you're less than 50 full-time equivalents by your renewal date in 2014. If you have 100 employees or less, you have to go into the exchange by 2016. And then 2017 is ultimately when we question we might end up being on a single payer plan. So in many ways, it's not really hidden. It's been very clear that if we go into the exchange in these sections, if you will, from 50 and under to 100 and under employees, that the state of Vermont is hoping to have a single payer by 2017, which means we'd all be on the same plan, and I have absolutely no answers with regards to how that would play out, because I'm not sure how it would work from a network standpoint or anything. But that's some time frames that are important for all of you.
Well, we don't have any other questions, Stephanie, so I want to thank you very much for spending your time with us and offering all of your knowledge and research and all the time that you've spent on learning all about Vermont's health insurance changes and the upcoming exchange. If you want to contact Stephanie for further information, we're going to put her email address up on the screen here at the conclusion of this broadcast. We thank you for viewing, and thank you, Stephanie, thank you to everyone in the room, and hope you all have a great day.